So I'm here to talk to you today about a big event in the past year, which was the release of DSM-5, which had a lot of significant changes for the entire manual, but specifically major changes for the diagnostic criteria of autism and related disorders. This topic is one that's been a big part of my doctoral training. As was mentioned, I trained with Dr. Kathy Lord at University of Michigan, and her research is almost exclusively focused on the development of diagnostic instruments for the accurate diagnosis of autism. And while that's not something that my research is focusing on currently, it's definitely encompasses issues that have been thoroughly infused in my research expertise and my clinical training. So I think it's important to just start off with, why are diagnostic labels important? As was nicely summarized by a couple of UCLA physicians, one of whom is a CART member, receiving a diagnosis has significant implications across many systems. So clinical implications, psychological, cultural, economic, and political. For a family, the psychological impact of receiving a diagnosis, having a label for the difficulties that their child may be experiencing, can be a really major life event, one that has a lot of, unfolds a lot of experiences that they're going to encounter along the way. In terms of cultural impact, receiving a diagnosis may impact an individual's conception of themselves as a person, their personal identity. And at the economic and political levels, a diagnosis, and really the clinical level too, but a diagnosis is really a ticket to services. Having that diagnosis on a piece of paper can determine what you're eligible for, what you're entitled to, and it has a lot of impact on how state and federal funding decides who gets the funding to be able to access appropriate treatments. So diagnoses do matter. The APA said itself that one of the most important changes in this edition of DSM-5 were the changes made to autism. I think that's pretty significant that out of this entire 800-page document, that the changes to autism were really some of the biggest and have had a lot of controversy surrounding them. But I just want to point out that change to our conceptualization of autism is not new. The autism was first included in the DSM just 30 years ago. So in the DSM-III, that was when we first recognized autism as a distinctive category. Since then, it's undergone a series of changes. DSM-III in 1987 was revised. That's when we first had the inclusion of pervasive developmental disorder not otherwise specified. Criteria were, can you see this arrow? Good. Criteria were further refined for DSM-IV and the revision in 2000. And this was where we got to our current system where we have autism, Asperger's disorder, PDD-NOS, Rett's disorder, and childhood disintegrative disorder. Today, with DSM-5, we've got some pretty radical changes. But again, I just want to highlight that change is normal. Change is needed in our diagnostic criteria. They don't always work very well. And as research continues, there are going to continue to be changes in the future. So DSM-5 is not the end-all. It's just another kind of step along the way. Well, why did we really need these changes for DSM-5? The fact of the matter is, clinicians were really bad at applying DSM-IV criteria. They didn't do it consistently. I'm including myself in that group. What I'm showing you here is a figure from Lord and colleagues, and these are data from the Simon Simplex collection, which has a table outside. This is a study that has extremely stringent requirements for training on diagnostic instruments. So well-qualified clinicians are administering what's become known as the gold standard for diagnostic practices, the ADOS and the ADI together. They're also administering cognitive tests, language tests, gathering a ton of information. And what this figure shows is that even when distributions of scores of the children who receive these evaluations, even though those distributions were the same, the distributions of best estimate clinical diagnoses are all over the place. So you see these dark bars down here refer to diagnoses of autistic disorder. The gray purplish bars are diagnoses of PDD-NOS, and then the light blue bars are diagnoses of Asperger's. And there's a lot of variation. Each bar represents a different site that's included in the Simon Simplex collection. And you can see that the clinicians weighted information in very different ways. Before you ask, I don't know which site is which. It's probably in a locked vault somewhere. But just to point out some of the variability, there are some sites that very rarely assign diagnoses of Asperger's or PDD-NOS. There's one site that never did. The range of percentage of Asperger's diagnoses ranges from 0% at this site up to 21%. And then it became clear that different sites were weighting information differently, and sometimes in ways that really are not well validated. For example, there were some sites that would assign a diagnosis of Asperger's to children whose mothers had higher education levels. That's very concerning. So in all, clinicians weren't doing this very well, even clinicians with very high levels of training. The goals of the DSM work group, of which Kathy Lord was a member, were to first in step with the entire DSM manual, but to come to a better integration of categorical and dimensional assessment criteria. So the emphasis on dimensional kind of underlying mechanisms of diagnoses is really important in DSM-5, and I think is a nice direction. Another goal was to identify characteristics that are associated with all individuals on the autism spectrum across age and ability level. And so what happened here, which was really significant, is that the umbrella term of PDD has been taken away, and all 5 diagnoses that were included in that have been collapsed into one single category. So ASD now represents those former diagnoses of autistic disorder, Asperger's disorder, PDD-NOS, and childhood disintegrative disorder. Rett's disorder has been removed because it's a known medical condition. The goals for changing the ASD criteria were also to improve the diagnosis without limiting sensitivity, so making sure that it still is picking up on all of those kids who do have autism. And just for the record, I use the term autism and ASD interchangeably. They also wanted to be really careful not to substantially change the number of children diagnosed. So we didn't want to have happen that kids who had an existing diagnosis under the DSM-IV criteria would lose their diagnosis or kind of fall off the spectrum, if you will. This graphic shows kind of one of the bigger conceptual changes to the DSM criteria, and that shows, again, moving to one integrated spectrum, referred to as autism spectrum, and then taking the triad of impairment that we've become very familiar with and collapsing that into 2 domains that represent ASD. So now instead of having social impairment and communication, deficits in communication as separate domains, these have been collapsed into a social communication domain, and the restricted and fixated interest domain has remained as is. So the current DSM autism spectrum disorder criteria represent these 2 domains that I've mentioned. So persistent deficits in social communication and social interaction, and then restricted and repetitive patterns of behavior or interests. These symptoms must be present in early developmental period, and I want to highlight this because there is a change here, which is pretty interesting, I think. Symptoms still must be present in early developmental period, but it's possible that they may not manifest until later. And that's something that the DSM is now allowing us to recognize. So some difficulties or impairments in social communication really aren't observable until a child is in an environment where the demands of the environment exceed their abilities. So now we can recognize that explicitly. We need to see clinically significant impairment across environmental contexts, and then you have to be careful to make sure that these impairments aren't better explained for other reasons, such as intellectual disability or global developmental delay. And looking specifically at the A domain, that of social communication, this has now been conceptualized as 3 areas of impairment. And for an individual to meet criteria in the social communication domain, they have to meet all 3 of these. So that's kind of a higher standard than DSM-IV. We expect to see deficits in social emotional reciprocity, so looking at things like social approach, back and forth conversation, interest in sharing and giving objects in younger children. We expect to see deficits in nonverbal communicative behaviors, so looking at things like eye gaze and use of gestures, and also one's understanding of gestures. And finally, deficits in developing, maintaining, and understanding relationships. So expecting that there would be age-appropriate peer relationships in the child's life. One thing that's new for DSM-5 is that you not only have to assess whether these impairments are present, but now clinicians are also called upon to specify the severity to which these impairments are present. I'm going to talk more about that later. In thinking about the B domain, restricted and repetitive patterns of behaviors, interests, or activities, RRBs, we look for stereotyped or repetitive motor movements or use of objects. What's new to DSM-5 is that now we've included repetitive speech in this domain. Previously, it was encompassed in the social communication domain, but now it's been pulled out where it's perhaps more appropriately represented in the RRB domain. So things like stereotyped speech or echolalia, the use of idiosyncratic phrases are now at play diagnostically in this domain. You also see insistence on sameness, inflexible adherence to routines, highly restricted or fixated interests such as a preoccupation with unusual objects like a paper clip or a piece of string, circumscribed interests that are age appropriate but just very intense. I think those of us in the Casri lab deal a lot with trains and roads and things like that. And finally, what is new to DSM-5 is the inclusion of hyper or hypo-reactivity to sensory input. So this is something that we've been assessing in diagnostic evaluations and that we deal with clinically in treatment, but it wasn't something that was included as a diagnostic feature. And so this is a pretty big change. This is now, a child doesn't have to meet all of these, B1 through B4, but they should meet at least 2 in order to meet criteria on this domain. And again, we are now expected to think about severity when it comes to restricted and repetitive behaviors. So I like this graphic because it really kind of encompasses everything that clinicians are now instructed to think about when applying an autism diagnosis. So this highlights that we're thinking about these 2 criteria, but that there's also a lot more important information that is not necessarily unique to autism, but should be considered when thinking about overall level of impairment. So we should think about language level of a child or an adult and their intellectual and adaptive functioning. As I mentioned before, really think about type of onset. Is it early onset? Was there a regression? Or is this something that wasn't clear until later in life, perhaps school age? We are now allowed to consider comorbid symptoms. So does a child with autism also meet criteria for ADHD or mood disorder? Many kids do, and we're now technically allowed to do that in practice. Also the consideration of medical conditions. Moving on to this concept of severity across the domains. This is something which is very new to the DSM. This is a reflection of the more dimensional approach, but for autism, I think this is one of the areas where there might be kind of some interesting fallout and need for more clarification. So we are now instructed to think about social communication and restricted and repetitive behaviors across levels of support. And that's how we're kind of considering severity. A child at the level 1 level of severity is someone who just requires support. Level 2 requiring substantial support, and level 3 requiring very substantial support. I'm not going to read these, but they're really not that different. So I think one thing that we'll have to think about later on is what exactly this means and whether there are any benchmarks for how we consider severity. But I think it's good that at least the DSM-5 is highlighting that we should consider severity. So when including a diagnosis in a clinical report, for example, a diagnosis of autism is going to look pretty different. It now comes with a lot more information. This is just an example that I've put together, but now we would assign a diagnostic label of autism spectrum disorder, potentially associated with a medical condition. So in this example, Fragile X syndrome. You have to include these severity levels. So this would be a child requiring substantial support for deficits in social communication and also substantial support for restricted and repetitive behaviors. The inclusion of these specifiers for intellectual impairment and language impairment is very important. And we're instructed to not only report whether there is an accompanying impairment, but also give some more details about it. So for autism, very important to not just to consider overall IQ, but to split that out and to think about verbal IQ and nonverbal IQ separately. And for language impairment, to think about, well, how much language does a child have? Is he or she nonverbal? Does he have single words? Or perhaps fluent speech, but impaired quality? And then, as I mentioned before, consider the addition of other neurodevelopmental, mental, or behavioral conditions. So to sum up the changes, we've gone from a multi-categorical model to a single diagnostic category. So we did lose some diagnoses, but they're encompassed in this new diagnostic category of ASD. We've gone from 3 domains to 2 domains. We're considering developmental trajectories so that symptoms will change over time and might not manifest until later. We have new symptoms to consider. We've always been considering them, but not necessarily for diagnosis, sensory interests, and aversions. The inclusion of language and intellectual functioning as specifiers, the inclusion of severity levels, and also the allowance of comorbidities. Now, I haven't said this explicitly yet, but I want to make sure I do this because it's very important. In the shift from the multi-categorical model to the single diagnostic category, anyone who had a well-established DSM-IV diagnosis of PDD-NOS, Asperger's, or autism has a diagnosis of DSM-5 ASD. So they're not losing their diagnoses as we shift from one system to the next. They're just being encompassed in this new one. How have the changes in the DSM-5 been received? It's been kind of a wild ride, I think, for the DSM-5 work group over the past year. Ever since the proposed changes were released, there's been a lot of public outcry, a lot of it well-founded. And this table summarizes some of the publications that came out either in support or opposition of the DSM-5 changes. And most of the criticism that was opposing the changes was the concern that some people would lose a diagnosis or that these new criteria would not pick up on kids who may not have as severe or impaired presentations of social communication features specifically. So the concern is that those who have diagnoses of PDD-NOS or Asperger's might be missed by the DSM-5. One point I want to make is that many of the articles that kind of came out swinging against DSM-5, there were some limitations, sometimes significant limitations in their methodology. So these were all retrospective studies, and the one that really caused quite a stir when it was quoted in the New York Times was that by McPartland and colleagues. That was actually based on information from the DSM-IV field trials, which included information or included participants who had received diagnoses under DSM-III criteria. So these data were simply outdated. So I think that's one of the biggest kind of criticisms of some of the studies that came out with strong concerns and caused a lot of stir publicly. But there have been more recent studies that are supporting the DSM-5 changes. This is an article by Mandy and colleagues from the UK, and it's a complicated figure, but basically what it's showing is that in their use of confirmatory factor analysis, they found that the 2-factor model, so looking at the DSM-5 criteria that included the 2 domains instead of 3 was the model of best fit. So there's a lot of support for kind of looking at social communication or social affect separately and looking at restricted and there's a lot of support for looking at communication and social interaction together, and then also considering restricted and repetitive behaviors. This is a table from Maricela Huerta, who's part of Kathy Lord's group, and I think this is probably one of the biggest papers that laid a lot of the concerns to rest. I'm not saying that they're all gone, but certainly kind of promoted more acceptance of DSM-5. And what they did was they took data across 3 very well-defined samples of children. So it included the Simons Simplex collection, it included the Collaborative Programs of Excellence in Autism, and also data from the University of Michigan Autism and Communication Disorders Center, UMAC, from its data bank. So in total, they had about 4,000 probands. And what they did is they looked at children who met for a PDD diagnosis under DSM-IV and considered whether they would still receive a diagnosis under DSM-5. They calculated sensitivities and specificities, so looking at who would be ruled in if they had autism and who would be ruled out if they didn't. Sensitivities looked pretty good. They were equal, if not better, than sensitivities from DSM-IV. And considering specificities, so the ability of DSM-5 to rule out those who do not have autism, they were lower, but still a vast improvement from DSM-IV. So when we look at this statistically, the DSM-5 is working quite well. In response to the concern of individuals falling off of the spectrum or losing their diagnosis, this is something that they considered very carefully. These three pie charts represent each different sample. The blue areas are children who had a previous DSM-IV diagnosis of PDD, so either autism, Asperger's, or PDD-NOS. And the red areas are children who had non-PDD disorders under the DSM-IV. So it included children who had anxiety disorders, ADHD, global developmental delay, but not autism. And so what we see here is that most of these pie charts are blue. So most children who had a DSM-IV diagnosis retained that under DSM-5 criteria. Now there were some children who didn't meet DSM-5 criteria, but I just want to point out that there weren't that many. And when a lot of the concern was that these children who, as I said, who met criteria for Asperger's or PDD-NOS, so those who have the impaired social communication qualities but might not have the restricted and repetitive behaviors, there was concern that they would be the ones who are impacted the most by DSM-5. And in this study, at least, that wasn't the case. So individuals who met the social but not the restricted and repetitive behavior criteria are actually those in these dark blue sections, and there were fewer of those than the opposite situation for those who met restricted and repetitive behaviors but not social criteria. So again, overall, DSM-5 is working well in kind of parsing these children out, but that doesn't mean to say that for those individuals who are falling off the spectrum that that's not important and that's not worth being concerned about. So what will happen to those kids who no longer meet DSM-5 criteria because they don't have restricted and repetitive behaviors? Well, the response from the DSM-5 work group was to create a new diagnostic category, and that is social pragmatic communication disorder. And the way that this is defined is that children will present with persistent difficulties in the social use of verbal and nonverbal communication. And so this is going to sound very familiar to the social communication criteria for autism, but that's deficits in using communication for social purposes, difficulty kind of changing conversation skills across contexts, difficulty following rules for conversation, your turn, my turn. I don't get to speak for 10 minutes about one topic specifically, and also difficulties understanding what's not explicitly stated, so difficulty with kind of figures of speech and things like that. Very similar to the autism criteria, these impairments might be present in early development but don't necessarily have to be, and they of course there should be evidence of impairment across contexts and impairment of overall level of functioning. And the last criteria, which I don't have on the slide, but is that symptoms should not be attributable to other medical or neurological conditions. What that really means is that symptoms should not be attributed to autism. So I think that there are some valid concerns about this as a diagnostic category. And when clinicians are considering, well, is a child presenting with autism or social pragmatic communication disorder, what they're really looking at are these two domains. So are there impairments in social communication? But then, most importantly, is there evidence of a history of restricted and repetitive behaviors? If there is, you would assign a diagnosis of autism. If there isn't, by default, you could assign a diagnosis of SPCD. So in an article where I think these issues were really nicely presented by Norbury, we're not quite sure what's going to happen with this diagnostic category. It seems like there's a high risk that this could become the new PDD-NOS, kind of the catch-all category where children fall when they don't quite meet criteria for autism. It's also concerning that this essentially feels like diagnosis by exclusion. If a clinician can't find any evidence of repetitive behaviors, then by default, you assign a diagnosis of SPCD. I don't think that's necessarily good practice. So as well summarized by this author, at least at this moment, there doesn't seem to be enough research evidence to really support this new diagnostic category. It's very possible that the DSM-5 work group was a little premature in including this. They had well intentions. They didn't want children to lose out on having a diagnosis that might connect them to services. But again, I'm not sure if it was quite time for this. So I want to end with focusing on, well, how do these changes, how does everything that I've presented thus far impact families, clinicians, and researchers? Well, I think probably the greatest impact will be at the family and individual level. And I think a lot of this is going to surround this issue of differential diagnosis. Is it autism or is it something else? And if there are symptoms of autism but not restricted or repetitive behaviors, is it social pragmatic communication disorder? This is going to have a huge impact on what services children are eligible for. At the individual level, it's definitely a concern. A lot of parents have raised the question of, can my child lose their diagnosis of DSM-IV, autism, or PDD? And as I said before, as long as they have a well-established DSM-IV diagnosis, they won't. They won't lose their diagnosis. They will then have a diagnosis of ASD on DSM-5. But that's if they've already been evaluated and you already have this on a piece of paper. For those children and adults who have never been formally assessed and who might have received a DSM-IV diagnosis in the past, it is possible that they won't meet criteria for DSM-5. So there are pretty serious implications for access to services. So organizations such as special education, supplemental security income, and disability insurance programs, laws protecting individuals with disabilities, and in Medicaid, of course, these are all agencies that provide services or supports or accommodations for individuals with autism, and we're not quite sure how they're going to respond to the inclusion of this new diagnosis of SPCD. I do want to say, though, that most of these programs don't specifically rely on DSM diagnostic labels. They don't use the DSM-5. They didn't use the DSM-IV. So I think for individuals who clearly meet ASD criteria, I think they'll be fine. They'll still probably fall into or within the descriptions of ASD that these agencies utilize. For those individuals who don't meet clear criteria for autism, there is a real chance that they might not be eligible for these services any longer. So that's something that we need to pay close attention to moving forward. In terms of impact on individuals, I think it's really important to mention that of cultural identity. There was a large outcry from the Asperger's community about losing that as a diagnosis. This was taken from an article that looked at blogging threads in response to the proposed draft of DSM-5, and individuals with Asperger's responded with feelings of fear, rejection, and sometimes defiance, a lot of angry feelings about losing this diagnosis, but there were also feelings of acceptance and reassurance. And so I think that, this is going to continue to be an area to keep looking at and to consider, and to be sensitive about what this might mean for someone who had a diagnosis of Asperger's and really identified with it, especially the strengths that often come along with an individual who meets criteria for what was previously known as Asperger's. In terms of the impact on clinicians, I want to say very clearly that DSM-5 is not the gold standard. As clinicians making diagnostic decisions, we really should not be running down the DSM-5 checklist. Decisions should be based on results from standardized measures, and all of this information together should inform a best estimate clinical diagnosis. Oftentimes, I know that clinicians are limited by time and funding, and so going down the checklist is sometimes a necessity. But if that's the case, you should also have the responsibility of making a referral to a clinic that can do a thorough evaluation. Something that clinicians will really have to consider, they had to consider this before, but especially now, but what are the best practices for the assessment of ASD and now SPCD? Well, for autism, I think there's a lot of research evidence for the current gold standard diagnostic practice. And that includes getting information from a parent or caregiver interview, conducting an observational assessment, and conducting cognitive and developmental and language testing. The parent interview, at least at this time, that's received the most support is the ADI, the Autism Diagnostic Interview. And in terms of observational assessment, the ADOS is widely used. These aren't the only measures that have support for research support for using in diagnostic practice. But when used together, at least at this point, they still are the best. So it's very important that a clinician takes the time to administer these instruments and to integrate all of this information to form a best estimate clinical diagnosis. In terms of SPCD, unfortunately, there is no current gold standard. Again, it seems that the diagnostic practice for this disorder is going to be one by default. So there are some emerging checklists that might be helpful for specifically assessing for social communication deficits, such as the Children's Communication Checklist, but everything else was really not designed specifically to assess for SPCD. And so the use of the ADOS, which is common, or the use of other similar measures, it really might have some significant limitations in assessing for SPCD. So we have a lot more work to do in determining what the best practice is going to be for SPCD. Regardless of what instruments you're using in a clinical evaluation, this is a nice summary, again by Huerta and Lord, that talks about what you should be considering during evaluation. You should be thinking about diagnostic classification, but more importantly, what information do you need so that you can make specific and helpful recommendations for a family? What's the child's overall level of functioning? What behaviors and symptoms are most concerning for the family? The outcome that a family is seeking might not be a diagnostic label. It might be real-time help with things that are going on in the home. What resources are available for families? These are all things that we should be thinking about when working with a family during a diagnostic evaluation. In terms of impact on researchers, I think we continue to have a lot of work to do in looking at diagnosis of autism and related conditions. We need to really think specifically about phenotypic and the genotypic conceptualizations of the autism spectrum. I think we're going to hear a lot of exciting research about this, and we already have during the rest of today. I think here is the area that I'm most excited about. It is true that DSM-5 has eliminated subtypes that were behaviorally specified, though not very well. I think that we need subtypes. We need subtypes of ASD so we can think about trajectories in response to intervention. But I think we need to move beyond behavioral distinctions, continued emphasis on genetics and biomarkers, and what will really make the difference in how a child responds to intervention. So in terms of the DSM-5 and how it's going to unfold, time will tell. I don't know. I think that there's enough evidence that I do think it's an improvement from DSM-5, but how this actually plays out in communities, in research labs remains to be known. I know that Autism Speaks has put a lot of funding toward getting information about how well the new diagnostic category is working, and so definitely encourage researchers and families to report back to Autism Speaks and let them know what your experiences are. So in general, I think these diagnostic revisions reflect progress, but as usual, more research is needed, and all of that will inform the next revision of the DSM. Thank you.
Is there any idea when the next revision of the ADI is going to be available?
Well, that's a great question. I don't know. I don't believe there's a revised version of the ADI in practice right now. And so the ADI will continue to be represented by 3 domains, but the use of the ADI algorithms is still very well founded. And so I think the ADI can still provide a lot of information that would go toward a DSM-5 diagnosis. There are kind of relaxed ways that you can consider a child meets criteria according to the ADI, so it doesn't have to be meeting on all domains. You might just miss the mark on 1 or 2 of the domains and still be able to assign a diagnosis. So you're right, the ADI is not yet in step with this 2-domain conceptualization, but I think it's actually still quite useful in providing the clinician with a wealth of information from a 2.5-hour interview.